think it's important to screen for both. As we develop effective treatments for vulnerable plaque, it's very clear that screening for those plaques long before these plaques become clinically relevant is something that we can then go ahead and do something about. Step 2 is likely screening for atherosclerosis, because it is not at all unreasonable to consider that treatments for a vulnerable plaque will in fact be useful in treatments for atherosclerosis. Specifically, we know very clearly now that atherosclerosis develops stepwise year after year after year. There is no reason to wait for this disease to become clinically relevant before we begin our treatments in these clinical syndromes long before they indeed become clinically relevant. The second part of the question relates to whether risk factors for vulnerable plaque should be different than risk factors for atherosclerosis. The answer to this is probably not. We know very well now from histopathologic autopsy studies that indeed patients with atherosclerosis frequently develop vulnerable plaque as a subset of this disease. Therefore, it once again comes down to effective screening methods where we can in fact screen for atherosclerosis and on top of that understand which subset of lesions will become vulnerable and thus at the long term treat the entire patient both for the vulnerable plaque problem as well as the underlying atherosclerotic process.